Hello, good morning, and welcome to this MEDICA Deep Dive. Telemedicine, how remote treatment can improve care. I'm Ben Giese. I'll be your host and moderator throughout this event, and hope to drive some very interesting conversations. Before we get started, there is a question and answer function within this Zoom meeting. Those questions will get put through to our editorial team working in the background here, and then get put through to our guests and panelists. So any topics you already maybe have in your mind that you want to get some more intimate knowledge about, or if anything pops up during the chat, feel free to write within that question and answer function. Telemedicine has been something interesting because it's a technology that was always just around the corner. Many different ways to use it, but patients, practitioners, the whole industry was unsure of what to do with it. Now, the pandemic has changed this and allowed or even demanded its widespread acceptance. We now live in a time where those developing new possibilities possibilities for care through its implementation are in the driver's seat of change. We are pleased to be joined by three individuals who are doing just that. First off, we have Leah Schoenmacher. She is consultant eHealth, ZTG Center for Telematics and Telemedicine here in Germany. And we have Dr. Daniel Dumitru. He's chief resident, Clinic for General and Interventional Cardiology Angiology at the Institute of Applied Telemedicine at the Heart and Diabetes Center, Nordrhein-Westphalia. And Bridget Stabenow. She is a business architect within health IT for the Philips Corporation. Leah, let's go right off and tell us a little bit about yourself, what's your background, and what you're concentrating on at this point in your career.
Yeah, hello everyone, welcome and thank you for the invitation. My name is Leah Schoenmacher. I'm a health economist and I work for the Center for Telematics and Telemedicine since February 2022, as a consultant with a focus on eHealth. I quickly share my slides for my keynotes. Here they are. I want to talk a little bit about telemedicine in the healthcare system, especially in the German healthcare system, and the role of our company. A little bit about us. We are a producer, independent and neutral competence center for digitization of the health sector. And our role is to support digital innovation in healthcare, increase transparency, promote acceptance and dissemination of digital health. And therefore, we work closely together with the Health Ministry of North Rhine-Westphalia, which also finances us partially, and other fundamental players in the healthcare sector. And broadly speaking, we often act as a link between care, between science, between the digital healthcare industry and politics. What does this mean? What do we actually do? You can best sum it up as consulting, networking, and informing. We consult on different topics, including data security, cost evaluations, or dissemination strategies. And we are also active in public relations through organizing different kinds of events and creating content for various platforms to spread information. Before I go deeper into telemedicine, I want to give you a short definition and broad classification so you understand what I'm talking about, as there also exist different definitions and classifications internationally. We define telemedicine as the remote delivery of care through the use of information and communication technology, and it can be broadly divided into three kinds of telemedicine, which is telecooperation as the remote cooperation between different healthcare professionals, teletherapy as the remote treatment of patients, and telemonitoring as the remote monitoring and assessment of health indicators recorded by the patient at home and then transferred to the healthcare professionals, ideally automatically. Now we have a short look at the virtual clinic in North Rhine-Westphalia, which enables telecooperation that guarantees high levels of care quality close to the patient home, no matter where they live. And it can be seen as a best practice for the transfer of a telemedical concept that was successfully tested at a rather small scale in a research project, and then transferred to the broad routine care. What does the virtual clinic do? It basically provides a central platform through which accredited and highly specialized clinics on the one hand, and attending physicians on the other hand from outpatient or inpatient care can get in touch, and they can exchange knowledge digitally through the use of video conferencing and electronic case records. Since the beginning of its operation, the virtual clinic has organized teleconsultations for an increasing number of indications and healthcare professionals. Currently, 5 indications are covered that you can see here in the illustration. About 120 healthcare institutions are connected to the infrastructure, and over 4,000 teleconsultations have taken place over the last 3.5 years. How does the ZTG contribute to this development? Since the beginning of the research project that the virtual clinic is based on until today, we continuously consult regarding the development and the operation of the technical infrastructure, and we support the public relation activities. We want to have another look at telemonitoring or remote monitoring, as it's a field of telemedicine which gains an increasing interest because it enables continuous care, which is especially important for chronically ill patients to detect exacerbations as early as possible. And in Germany, it's mostly conducted by telemedicine centers. Here we see the traditional care pathway, and here you can see how the telemedicine center interacts with the patient and the attending physician in this new care pathway, including remote monitoring. And what it basically does, it is responsible for the data management, the data collection analysis, and then informs the attending physician about the results, especially when defined thresholds are exceeded. How is telemonitoring established in routine care in Germany? For patients with heart failure, it's covered by the German statutory health insurance. The SHI covers 90% of the population, so that was quite an important step, this transfer to routine SHI covered care. However, there are strict terms and conditions that apply with regards to the target group, with regards to the length of the monitoring intervention, and with regards to who can become a telemedicine center and who can become an attending physician in this covered use case. Therefore, telemonitoring, or still the majority of telemonitoring, occurs apart from SHI covered services, either in research projects or studies, through selective contracting, or as private services that are paid out of pocket by the patient. And what all of these have in common is that they limit the target group. There are chances for further and more comprehensive integration of telemonitoring into future care due to trends towards the delivery of traditionally inpatient services as outpatient care. Then the digitization of existing disease management programs for chronically ill patients is planned, and the extension of SHI covered health apps to medical product classes that allow the use in telemonitoring scenarios is also on the way. To close my keynote, what is the status of telemedicine? What are the current challenges and perspectives? In general, with a view to the German healthcare system, it is complex, and the implementation of digital innovations is rather challenging and time-consuming. The list of challenges is long, and I just want to point out one of them, which is the high fragmentation of healthcare, especially strict or strong between the inpatient and the outpatient care sectors, and as telemedical interventions often overarch different care providers from both sectors. This is a big challenge to overcome for the integration into routine care. Up to now, telemedicine is a very active and dynamic field, but only a relatively small number of telemedical pioneers are covered by the SHI so far. And what I believe is that the challenges of our healthcare system that it faces due to an aging population, which is a declining number of healthcare personnel and a growing number of chronically ill patients, it can only be adequately addressed by a further dissemination of telemedicine. So I want to end my keynote with a hypothesis that we need a seamless and comprehensive integration of face-to-face care and telemedicine to some kind of blended care instead of underrating telemedicine as a niche phenomenon. Yeah, thank you for your attention, and I'm looking forward to the discussion.
Yeah, and thank you very much. That was a great overview about the activities taking place within your institute, and also a very sober look at the current state and what challenges are faced. And as usual, it does come down to funding. So very, very sobering to hear your take on that. Dr. Daniel Dumitrescu, we understand you are in clinic and also not taking time off and putting your feet up. So if a call comes in, we understand if you have to be away 5 minutes or 10 minutes, or if it's an emergency. So I just wanted to get that on the table to start. We totally understand that. Please tell us a little bit about your background, how you came into the position you are now within the institution, and what your current activities are within the field of telemedicine.
Thank you very much for the nice introduction.
Great.
And thank you for announcing that if the phone rings, I might go away, but I don't think this will be the case, and I hope it will turn out well. Okay, so I will talk about the use case of heart failure for virtual medicine. And this is some kind of adding something to what Lea Schumacher said, and complementing these ideas and concepts. I will talk about two things. Number one is consultation for complex cases in heart failure, and the second thing is telemonitoring. So the first one is a communication between physicians, and the second one is some kind of communication between physicians, nursing teams, and patients themselves. So first, something about our clinic and about myself. We are located in the middle of Germany. We are a large hospital with 500 beds and more than 2,400 employees, 275 physicians, over 800 nursing staff. And we are Germany's largest heart transplant center. So we have a lot to do with heart failure. And we have an institution for applied telemedicine because we early had an interest, and this was as soon as 2003, that we need some kind of a connection between the medicine that we practice with and for our patients and the medicine that we practice when patients are at home. This means remote monitoring and keeping up the communication line with these severely ill patients. So I'm there since 2019. And I'm also part of the medical team in the Institute for Applied Telemedicine. And so my interest was connecting the medicine that I practice in the hospital. This means I'm involved in severe heart failure and right heart failure and in these telemedicine programs. And so this is a very good and fruitful connection. So if you look at heart failure, it is a complex disease. And it is not only, well, the difference between right-sided and left-sided heart failure, but it's also different aspects that may or may not come together. So it's a combined disease. You may have valvular problems. You may have coronary artery disease. You may have arrhythmias on top of heart failure. You may have inflammatory processes, pulmonary hypertension, congenital problems, and these things may all come together. And this was the idea of the virtual hospital North Rhine-Westphalia, of the Virtuelles Krankenhaus NRW, to be able to cover questions for these complex cases as a digital tool. This means you may with a web browser and a registration at the virtual hospital NRW, ask questions for complex cases, and contact an expert center, and in this case, the HDZ NRW, via a web platform. And we are a web platform that is safe regarding data protection laws. So this is a safe vehicle to transport medical data. So what happens? If you ask a question, we have one coordinating nurse, Dani Röfe, who checks all the consultation requests that come in, looks for completeness, and then transfers it to us, so the physician side of coordination, and we look whether the consultation may be answered by one expert from our team, or if we need to have a team meeting over several disciplines, and then give a structured report back to the physician who asked the question. Or in some cases, if there is the need to do it, and we do it very generously, have some kind of conference with the people who asked this question and really discuss the patient case. So coming to the second part. So this was communication from physician to physician. Now we come to communication between our team, the Institute for Telemedicine, and the patients themselves. And in the previous talk, we've heard about financing and programs for telemonitoring. And we have the special privilege that heart failure is financed by the insurance companies in the meantime. We started off with one program that went for a period of 24 months, where patients with heart failure in a certain functional class, so this means advanced heart failure, and previously happened cardiac decompensation within the past 12 months, who were insured by specific companies, so it was a selective contract, were monitored for 24 months. Now we have the chance to monitor every patient that is covered by state health insurance. This means SHI programs. It is restricted to 12 months. However, the inclusion criteria are a little bit stricter. So there is a certain number of the left ventricular ejection fraction that you have to document. This means it has to be real advanced heart failure. Cardiac decompensation has to have happened within the past 12 months. All patients have to have an implanted cardiac device, a defibrillator, or CRT therapy, and they need to be on optimal medical therapy in order to be eligible for the program. However, if they meet these inclusion criteria, we send them documents and devices to their homes. This means they get a blood pressure measurement device, they get a scale, they get a mobile ECG and a transmitter that automatically transmits the data daily from these devices to our database. We look at the database and see if patients are stable or not. And if not, we contact the patients with the hope to improve safety, to avoid another decompensation, and to improve quality of life, because patients just feel safer with this sort of communication. And this is an example. This was a 69-year-old lady who was in our telemonitoring program, and this is the body weight. You see that the body weight is going up, and at this point we called her and say, well, your body weight is going up. You should decrease your fluid intake. You should increase your diuretic dose. And so the weight went down again, and we avoided a decompensation. And as you look at the date, this was Christmas. And this is one of the challenges. You have to have a team that looks at these data every day. Otherwise, you will not notice these changes. We also do invasive measurements. This is a little sensor that is put into the pulmonary artery. It's really implanted there, and patients are measuring themselves with an antenna that measures pulmonary arterial pressures with this device. So they just sit down on the pillow, press a button, and then these measurements are recorded and transferred into our database. And this is how it looks like. So this is what we usually see after the implant of such a pulmonary artery measurement device, that pulmonary pressures goes down. And our interpretation is that patients realize, well, somebody's looking at my data now every day, and I'm really intensifying my treatment, or I take my diuretic dose every day instead of every second day. But the hope is, with this telemonitoring concept and the communication that we keep with our patients, to improve quality of life, to normalize pulmonary arterial pressures in heart failure, which is not possible in every case, but we see very large success rates, and we are able to follow these patients better when they are at home and not in our clinic. So as a closing statement, I may extend the closing remarks from Lea Schumacher. And from a medical perspective, what we do at the moment with telemonitoring is crisis management. So patients had a problem, they were decompensated in heart failure, and we tried to prevent decompensations. However, and these are the challenges from my point of view and from the medical point of view, we don't have any telemonitoring concepts that are funded at the moment who allow some kind of a health maintenance status. This means if we have treatment goals and share these treatment goals with patients, that they are able to manage themselves at home as long as they are stable within these treatment ranges. If they get worse, we are notified via this technical communication link that they have to us. And so we can switch between the health maintenance and crisis management concept and back. And from my point of view, this would be very interesting for heart failure, because it is a chronic disease, which in many cases is not curable, and would help stabilize patients for a longer period of time to improve safety and maybe even improve efficacy and cost efficacy, as it is a large health burden, not only in Germany, but worldwide. So thank you very much. I'm open for the discussion.
Great. And thank you very much. It's always great to have somebody within a conversation that's actually implementing these technologies that can really speak to the reality of the situation, both on a side of opportunity and a side of the realities of funding and the roadblocks involved. Moving on to somebody who I'm assuming will have a bit more optimistic view on the future, as being somebody responsible for looking at new possibilities and the way the market can meet current and future demands. Birgit, please tell us a little bit about yourself, your position within Philips, and what your company is currently working on.
Thank you very much, Ben, for the kind introduction. And I hope you can see my screen now.
Indeed, perfect.
Thank you. My name is Birgit Stabenau, and I've been working for Philips now for almost 22 years. So I've held various positions in the company, in customer service, in strategy and development. And 6 years ago, I joined what I still regard as the most interesting part, which is the informatics business. And why is that? Maybe some of you even don't know that Philips is involved in IT. So the majority of you will know Philips from the equipment that we do sell. All the MRCT machines, X-ray monitoring, that center around the patient and kind of extract data from the patient and turn the patient's disease into pictures, into data points. And what we do in the IT is to integrate all that data and to represent it in a way that it makes that enables the data to give actionable insights to the caregivers. So in my view, the IT is what really brings health technology to life. And this is what we do. And IT at Philips is currently already making up almost 20% of the annual revenue, so quite a lot. And we do that in the areas of radiology, of pathology, in acute care, and cardiology. And all of these areas are areas where and I call it, Leah, as you introduced the wording, telecooperation, because these are the expert systems that we do have that are needed for the telecooperation. My role in this game is being a strategic business architect. So I'm always involved when we go to new solutions, bringing together existing solutions to new concepts. And I think that's basically what telecooperation is about. And I brought with me some scenarios that are can be thought of in this area of telecooperation. We start here at the left. We often encounter situations where hospitals have already existing networks with other hospitals. Might they be real or virtual, like the virtual Krankenhaus Nordrhein-Westfalen? You can either have a standard cooperation with adding virtual resources from one hospital to another, or you just take it as getting a second opinion in rare cases. So everything is possible here, standard or on demand. Hospitals can use telecooperation to make themselves more attractive to staff, because working from home, especially, remember I said, for example, radiology, you can read images easily from home. And we do have a strong shortage in staff, especially in the medical sector. And I could imagine that there are a lot of people who wouldn't like to work a full shift in a hospital, but maybe 4 hours from home reading images would be possible. So I think that's a very important scenario, especially in the future. You can add freelance resources in the same way to your staff, or you can use a telemedical center to cooperate or again get a second opinion. So these are some examples of telecooperation scenarios. And as you can see, it varies. There is a lot is possible. There is no standard yet. And that leads to, in my view, the biggest challenges that we do have here, or that we encountered in our projects. Number one is the contractual setup. So really what you, Daniel, said earlier, what is reimbursed? How can we get the money back? Who pays what? Who does what? And of course, who is allowed to see what? Because we're talking patient data. This is sensitive data. You need to make sure that the IT is always secure and that everybody who's looking at a data point is entitled to do that. So these are the big pitfalls in these scenarios. There is no standard yet. But in this telecooperation, you always have this exchange between specialists. So that is where you need expert solutions for IT solutions. And this is, of course, what Philip is able to provide. And I brought with me 3 examples. As we already talked about telecardiology, I brought the other examples with me. In radiology, we see a huge demand to realize telecooperation scenarios. And for example, the PACS that we do offer, it has a mobile client, which is HTML5, working on HTML5. So it's easy to detach the reading from the image acquisition. And with this IT solution, it's basically possible to enable all the telemedical scenarios that I talked about earlier. And we do have customers who already use that in teleradiology centers. Similar is the pathology. And I wouldn't like to rate which shortage and stuff is more severe, but I encounter a lot of pathologists who are really desperate looking for new pathologists. The images are even more in volume in data. And what you need to do here is still the sample taking and the slicing and putting onto trays, and the scanning has to be done centrally. But once you have the images digitized, you can send them literally anywhere you like and do the reading in other places. For the tele-ICU, the solution is a little bit different. Here you see 6 monitors, and what the tele-ICU solution does is basically bring together the other systems that are centered around the patient, the PDMS, the monitoring. For example, a video connection can be established. And what is important here is to be independent from the monitoring manufacturers, so that you can integrate different systems here. And I'm getting into interoperability and integration later on. So that is also a nice solution, really, to realize telecooperation or telemedical scenarios. So these are the solutions that we do have today, and where are we going to tomorrow? And I'd like to I'd be dare to pose 3 theses here, and they're centered around that. We strongly believe that telemedicine is going to experience a strong rise in the next years. And why is that? Number one really is the shortage in staff. I already talked about that. And I think it will simply force medical institutions to use telemedicine more widely, to a high degree, to attract resources and to share the scarce resources that we still do have, for example, in the night shift, on the weekends, to really make this expertise available to different institutions. Number 2 is the hospital reform that we currently have in Germany. And it anchors the telemedical cooperation into the system. There is a cooperation between the level I1 hospitals and the others is required. And this whole reform carries the notion of distributed care cooperation. So this, I strongly believe this is going to push telemedicine further. And number 3, we didn't have that buzzword yet, but it needs to be in any IT discussion we have here. It's the cloud. And I see all applications, all health IT applications going into the cloud in the next years. And that will enable more telemedical scenarios, because more solutions in cloud means more flexible usage and more flexible integration again, because we're talking about ecosystems. These are the main drivers that we see. And I couldn't resist to put this small green icon here, because I'm a strong supporter of sustainability activities. And telemedicine also is an enabler for sustainability, because once you stop moving patients, you stop moving doctors, where you can facilitate that by telemedicine, it's also it's a relief for resources, and we shouldn't forget that. So these are the 3 theses that I would like to put. And there's one more buzzword that I would like to bring in here, and that leads me to the sneak peek. My colleague Julia Hagen is going to speak on the MEDICA about how AI can help healthcare professionals, to address the challenges they have today. And especially in telemedicine, I think we have a lot of scenarios. Daniel talked about the telemonitoring, where AI can help really to gain insights out of the huge masses of data that we are going to acquire. So I think that's a very important technology, especially with regard to telemedicine. And Julia is on the 14th of November at the MEDICA talking about this topic. So if you like to drop by, she'll be happy. She's a great speaker. And yeah. With that, I would like to hand back to Ben, and I'm very much looking forward to the discussion.
Well, thank you very much. That was a very concise view at what Philips is bringing to the market. And I agree with telemedicine and AI. It's really hand in hand with one another. Telemedicine, by definition, is the digitalization and the communication, the transfer of data, which lends itself automatically to AI analysis and supports through the upcoming AI revolution, to use an even buzzier word. So let me take that over from you. Leah, back to you. As you started off, I would like to find out, what is your typical first contact? What are the pain points that somebody within the healthcare industry is experiencing that they come to you to solve?
Well, I think this typical contact does not really exist, because it's pretty much always different and depends on the perspective, on the role the person or the company that contacts us has. But I can give a few typical examples. For example, we have international companies that contact us, and they have some sort of telemedical solution or product with that is matured market-wise already, and potentially has also entered the market in the home country or the origin country of the company, and now they want to expand to Germany. And there, it's often about getting to know the health system in Germany first, the characteristics and particularities, and identify the chances the product has to enter this market successfully, and define a business case. So we nudge into this direction mostly for this target group. And then there are also care providers that can contact us that want to start with telemedicine, and they are either overwhelmed by all the information they find from different sources, are not quite sure what they have to consider, or they don't find the right information. So then we are there to give an overview about the facts, and also refer to trustful sources and additional supportive structures. And that was especially often happening during the peak phases of the pandemic, when a lot of care providers wanted to start out of a sudden with teleconsultation or video consultations, for example.
I can imagine that must have been an incredibly busy time for the institution. So you're seen by a lot of players within the healthcare industry as a neutral consultant, as somebody who can provide possibly non-commercial advice of the best existing technology and where to take their development in the future.
Yeah, exactly.
Great. Okay. Daniel, in your day-to-day, you're already implementing telemedicine deeply within very specific cases and uses. Just in the hour-to-hour work as a physician, where do you see telemedicine? Where is it failing? Where could it be used more to assist you just in the daily life of a physician?
That's a really good and important question. I mean, first of all, as Birgit has shown it very nicely, we have some kind of closed ecosystems within telemedicine applications. And we have in our daily life, even in our institution for telemedicine, several systems running one next to each other. This means we have to look into different applications and enter different ecosystems in order to get a whole picture, and at our end synchronize all the data, that we don't have 3 parallel data streams running without being synchronized. So a little bit of improvement in interoperability and interfacing between different platforms or telemedical solutions would make the work more easy. However, we have made large advances in the past time, and maybe commenting on your last slide, Birgit, with the little green icon that I loved, I would add a red heart next to it, because those who profit most of these concepts are the patients themselves, especially in heart failure. These are really sick people who are not able to walk more than 200-300 meters without stopping and regaining breath. And so we might save them hundreds of kilometers for a drive to the next heart center, which they would have to do in regular time distances, or if they get worse. So if they have this opportunity, this not only saves resources for us, but it also saves resources for the patients.
Birgit, right to you. If somebody approaches Philips and mentions this, they're worried about their data being siloed. It's not interoperable with other departments possibly, or like Daniel said, you have to log in, log out, look at different screens, etc. I would imagine Philips would be there to say, yes, welcome to our complete ecosystem, which is not always what institutions want to do. So how do you handle that balance between what would be best for your company, which would be just onboarding everything, so it's more user friendly, and legacy systems and the reality of healthcare? How do you balance that in your approach?
That's an absolutely realistic situation that you describe, Ben, because interoperability, as Daniel said, it's the biggest demand or the biggest need that we do have currently, that I see in health IT as we deploy it in the hospitals and in the whole healthcare system. No, if customers ask us, we don't say, here's our complete ecosystem, take it and you'll be happy. We do, and I showed we are we have mainly 4 areas where we are active and where we do offer our systems, and we do put a lot of emphasis in integrating really end to end. From the patient, as I said, our equipment, they extract the data from the patient and we pick it up in the health IT, and we want to process it so that really caregivers, care providers can really work with it. So what we do is we don't invent the whole story of IT. We only have specific elements and we make them interoperable. And we do have standards. We have IHE. We have HL7, we have FHIR coming new in, and also the ESIC in Germany. I think, well, yeah, you can always say it's not sufficient. No, it's not, but it's a start. And we go in that direction. That's something that I do like. And in more and more tenders, we see that really interoperability is a knockout criteria. And this is a must in my view. And any provider who doesn't adhere to that, in my view, will be non-existent in 3 years from now, because there is no way that you gain such a market weight and overdrive customers, or all customers that we do have. They have various vendors, and that's important to keep the balance. So we need to be interoperable, and once we provide the best solutions, people are going for our solutions anyway. So we strongly vote for interoperability and for just being the best to be chosen.
Mm-hmm. When you're dealing with the healthcare industry, not in a sales perspective, but possibly just knowing that there are great systems that could benefit institution X, Y, or Z, what are the biggest issues you face, or where do you think possibly institutions themselves, or in interplay with government or funding agencies, whether it be insurance or government-supported healthcare, how could those people all work better with one another to increase the acceptance of telemedicine?
I think the acceptance is there. All people with whom I talk, they're very positive, very open. What we really do need is what I would like to call the coalition of the willing. Really, we do not, as Leah said in the beginning, right at the beginning, there is no standard yet. We do not have the ways planted out, and you just need to ride it through. You need to invent things. You need to try out. You need to be creative, and you need to convince people. When you create a network like the one in North Rhine-Westphalia, that was a huge effort, and you need to put that effort on top of all the efforts that you have in daily life anyway. So really, you need people who burn for that topic, who really want to do it, and who say, okay, we're going to do it. Who's in with me? And these are the people who are going to scout telemedicine into the next 5 years. I think that's what the systems are there. The medical caregivers are there, the patients are there, technology. So just we need the people who drive it through, in my view.
Yeah. Okay. Please, yeah, Daniel, go ahead.
May I add to this? Because I think that this is the core of the whole challenge. It's about trust.
Yeah.
It's about trust from all parts of the healthcare providing system. If patients and physicians and companies don't trust each other, this will never get to work. And on the other hand, it takes really a long time to develop trust so that people join the network and say, well, it's a benefit for everyone, for the patient, for us. It somehow facilitates working and benefits the patients. So speaking of this example of the virtual hospital NRW, it took a very long time to get people attracted to this idea. We had the expert consultation opportunities present for a long period of time until the first real questions came to us. So you have a time delay, and I think it's also connected to the trust issue. So if nobody knows of that, and you ask your peers and they said, well, virtual hospital, never heard about it, I guess you will not easily use it. On the other hand, if you have some kind of a living network and you ask your peers, well, have you ever used virtual hospital? And somebody says, oh yeah, it's working well. I've had good experience with that. You build trust, but this takes time. And I think now we are in this transition phase where we create this living networks, as Birgit already stated.
Just a follow-up question. You mentioned trust. My initial reaction when you described the remote monitoring opportunities through telemedicine, I have family members who are using some of those systems for blood pressure monitoring, wearable EKG, recording devices, etc. What's your take on patient acceptance and efficacy of use? Are they doing generally a good job in keeping track of equipment and using it correctly, or is it a lot of work to get a patient to the right place and use the equipment correctly?
Well, it's surprisingly good. It's better than we would have expected.
Okay.
I think one prerequisite is that you design the app and devices in such a way that the patients can use them easily. So just step on the scale, turn on a smartphone or a tablet or whatever, and the data is transmitted. And the second point, you get feedback. So you transmit your data, but you know there is somebody looking at it, there is somebody contacting you. And I think when these two things come together, even older patients are using these devices very reliably. And we were really surprised. And the third thing that we were not aware of in the beginning when we started our programs, even with older patients, the family is behind those patients. And they are really grateful that somebody is really looking at the data and that we can be contacted in case of problems. So the family also helps these people and patients to use the devices correctly and to remind them, well, have you measured your body weight and have you done your daily procedures? And so it's increasingly well used. And
Yeah.
I think it's a simple concept. I mean, we use 3 minutes twice a day to brush our teeth, and it's not very difficult to convince somebody to use 3 to 5 minutes a day to take care of your cardiovascular health, and they are really doing that in the real world.
That's an aspect I had never considered. That makes a lot of sense. Through the telemonitoring, in many cases, it's an automatic generational integration into the health of another family member. That's a very fascinating point. And I can see the benefit of it as well. You have, it becomes collaborative. It becomes a topic of conversation with people taking care of each other. That's interesting. Leah, back to you. What are, from your perspective, as we've established you as the neutral arbiter, what are some of the things that you would recommend practitioners, managers, people involved in healthcare, what questions should they be asking themselves? What should they be looking around for within their hospital? And what should they be reaching out to you to solve?
I think we heard a lot of the aspects already. We heard about interoperability, we heard about legal issues, we heard about funding, about trust. Another aspect I think is very important, that as a care provider or as a healthcare institution, you have to realize that implementing a telemedical solution is not just about installing a software or learning the roots of a new technology. It's a lot about changing care and organizational processes as well. And yeah, that simply takes effort, and naturally you have this instinct to keep the routines you build up over a lot of years, and you need mood or courage as well to do so. So it's the first challenge is to realize this need, and the next challenge is that as Birgit pointed out before as well, this to address this need, you need time, and you have a big workload anyway. So it's a challenge to find and take this time to reflect and adapt the processes around the telemedical solution.
Mm-hmm.
I think
Ben,
you're
Ben,
muted.
you're on mute. Something dropped onto the.
Yes, indeed. Thank you very much. You were spared for me for 20 seconds. Staying with you, Leah, are there certain ideas or methods that many healthcare providers find attractive, but you would not recommend them to do? Is there, we talk about buzzwords. Are there systems that people come to you and say, how can we do this? And you tell them, through our experience, it's not a good idea, it's too early, it won't work, etc. Is that something you encounter?
I'm thinking now. No, I don't come to an example of this right now. I think it's best if people are open to a lot of things. We heard AI, for example. We would never say, "Oh, it's too early." I think it's already a technology of the present, not of the future anymore. So I think it's good actually to think big, and even if you have to start with a less far-arching goal, you still should keep these these more enthusiastic goals in mind. Yeah.
Mm-hmm. And just get started. Okay. We are at the end of our talk. Birgit, I want to give you an opportunity to let us know about the presentation by your colleague again at this year's MEDICA.
Mm-hmm. Yeah, thank you very much. That's picking up the topic of artificial intelligence, AI, and the colleague is Julia Hagen. I can quickly just get that slide up again. There it is. So that's Julia Hagen, and she's going to talk about AI in healthcare at the MEDICA at 14th November. Just after lunch, so just drop by and yeah, take these 15 minutes to listen to this talk. It's certainly going to be very interesting.
Great. Thank you very much for that. Leah Schomacher, Dr. Daniel Dumitrescu,
yeah,
and Birgit Stabenow. It's been a great talk. I appreciate your open, honest conversation, and really giving us a good look, an honest look into telemedicine today and where it's going to go in the future. So thank you very much for joining us. And to our audience, thank you also for joining us for this talk. If you will be at the MEDICA between the 13th and 16th of November in Dusseldorf, if you see me coming through, we'll be doing a lot of camera work at the show, doing a lot of live reporting. Just grab me for a conversation. We can talk about many topics. I'd really appreciate that. And if you haven't decided to go yet and you're still on the fence, please do consider it. It really is a great opportunity to find out new technologies, new ideas, new processes, solutions within the healthcare sector for today and into the future. Thank you all for joining us, and thank you to our panel.
Thank you very much.
Thank you.